Welcome to the Leukemia and Lymphoma Society of Canada's webcast called ASH Annual Meeting Highlights. This presentation is part of a series featuring the latest scientific research and education on the hottest topics in hematology and hematology-oncology. In this presentation, you will learn how these rapidly evolving developments can help improve the management and care strategies in patients with hematological malignancies. Let's start the presentation. My name is Sonia Muto, Community Program Coordinator for the Leukemia and Lymphoma Society of Canada. I will be the host of this online event. During the webcast, you will hear only my voice and the speaker's voice. Since there are many of you, questions may be asked at the end, but only online using the chat function. The presentation will last approximately 1 hour and will be followed by a 15 to 20-minute question and answer period. This presentation is being recorded, therefore you will be able to listen to it again on our website while following along with the PowerPoint presentation. We will send you an email notification when everything is available online. Our mission is to cure blood cancers and improve the quality of life for patients and their families. We offer support to people affected by blood cancer every step of the way. Please reach out to us if need be. We also have several informative tools on our website, llscanada.org. The Leukemia and Lymphoma Society of Canada is financing 35 research projects in 2017 and 2018 and has invested a total of $40 million in research since 1955. I would now like to introduce our speaker, Dr. Mona Shafie, who has generously accepted to share her knowledge with us. Dr. Shafie is a clinical associate professor for the Department of Medicine, Division of Hematology at the Foothills Medical Center and University of Calgary. Over to you, Dr. Shafie.
Thank you, Sonia. These are just my disclosures. I do not have any current grants or research support through any commercial companies, but I've had honoraria through speakers bureaus of multiple different pharmaceutical companies. I just wanted to give you an idea of what the ASH annual meeting was like. It's the American Society of Hematology meeting that happens every year in December. And it's the premier event in presenting new data in patients with malignant and non-malignant hematological diseases. It's a very intense 4-day event, highly educational, and we get updates on the hottest topics in hematology, consisting of educational sessions, scientific sessions, special symposia, plenary sessions where the top abstracts are presented, and then late-breaking news for topics that are likely to change standard practice. Well, throughout these 4 days, over 4,000 scientific abstracts are presented and discussed. And in terms of attendance, more than 25,000 hematology professionals attend this event. So it's a very busy 4 days, but highly educational and valuable. We all who attend this bring this information back to our colleagues who were not able to attend. So what I'd like to do is present some of that data. The abstracts that I have selected, I think, will be of interest to many people across Canada. And really, I'm going to touch upon a few things. One is to look at biomarkers and molecular testing at the diagnosis and prognostic level of patients with hematological malignancies. The bulk of the talk is going to talk about the treatment, so the state-of-the-art therapeutics in hematological malignancies, and I focused on things that would likely to change practice in Canada. And then lastly, I have a couple of abstracts talking about some other supportive care measures that complement these therapeutic strategies, really to improve patient outcomes, decrease the risk of complications. And so I really have to stress that what I've chosen to discuss is really the tip of the iceberg, but stuff that I think would be applicable to patients across the country. So the first thing I'm going to talk about was the molecular testing, really from a prognosis perspective, focusing on two diseases, myelodysplastic syndrome and acute myeloid leukemia. So myelodysplastic syndrome, this is a disease of the bone marrow, and unfortunately, it leads to one of two consequences. One is bone marrow failure, so in which patients' blood counts start to drop. They may require blood transfusions, and they may have complications from their low blood count. The other as significant complication is the development of leukemia, generally acute myeloid leukemia. It's an important disease, and we see more than 2,000 new cases in Canada each year. So when I see a patient for the first time with a new diagnosis of myelodysplastic syndrome, one of the first things I want to know is, what is their prognosis? And patients want to know this as well. They need to plan. They need to know, is this going to be something that's going to affect their life in the near future? And we often use the information we get at the diagnosis to give them a prediction. So we look at their clinical factors, their blood counts, their bone marrow results, and some of the special testing we do, primarily cytogenetics, to help us stratify these patients. And it tells us, you know, whether or not their prognosis is very good, so they tend to have low-risk disease, and their disease survival is measured in many years, or if they have poor-risk disease, meaning their disease survival is measured on the order of months. And this helps me decide how aggressive I want to be in terms of treatment, and helps me choose what therapy is appropriate. The interesting thing, though, about myelodysplastic syndrome is that it's very heterogeneous. So even amongst the people who have low-risk disease, there are the people who expect to do well, but then there's going to be a small proportion of people who don't do well. And it's those people that I want to identify early to see if I can treat them. And the flip side is people who are very high-risk disease, who are not going to benefit from the certain treatments that we have, or actually have a very good prognosis relatively, because they have certain mutations that might give them a survival advantage. So in this particular abstract, the author created a model to analyze not just the clinical data that we all have access to, but genomic data. So this is data that's obtained from the bone marrow cells itself, and going through some genetic testing, identifying mutations, and then putting it all into a computer system that then spits out information about the prognosis. And so basically you put in these variables, and it gives you an output, and it predicts what's going to happen to that patient at different time points. So it was really, really interesting in terms of seeing what would happen when you put this information in. And what's also useful is that it was actually better using this particular model in terms of predicting prognosis compared to what we used to do, which was just looking at their blood counts and their cytogenetics. And what was very attractive is that the author wants to create a website where people like myself, you know, remote from their site, can put in the patient's characteristics, and then I can get estimate on their survival, and then allow better prediction of what will happen to them. It allows me to select more personalized care for that patient. So overall, I can use that information better suited for that patient. The patient will receive more accurate information in terms of their prognosis, and can make some decisions regarding their care. Moving on to acute myeloid leukemia, this is the most commonly diagnosed adult leukemia, and unfortunately the one that's associated with a very poor prognosis. And it tends to hit older patients, so on average age over 65. And this group is very difficult to treat because they don't tolerate very intensive treatments very well. And so the idea of this BEAT AML study was to bring together a whole group of people involved in different areas in the care of a leukemia patient. So this was organized by the Leukemia Lymphoma Society, and it brought people in academic institutions. It brought in the pharmaceutical companies who are making the drugs. It brought in the regulatory agencies. This is an American study, so this was the FDA, the genomic testing group, and then the people who run clinical trials. They brought them all together to create this precision medicine clinical trial. And essentially what it was trying to do is identify patients with a new diagnosis of acute leukemia, and then get them on to a clinical trial with a drug that is best for that specific type of leukemia. In the hopes that if patients get treatment that is more targeted towards their specific type of leukemia, that they're going to have better outcomes. So these are brand new patients, and really the only inclusion criteria was that you had to be over the age of 60 and with no prior history of treatment for that leukemia. It's a very early study, so the first patient was enrolled just over 2 years ago. So what was published was really the feasibility, how well they did in terms of getting people onto clinical trials. We don't have as much data in terms of what happened to these patients, but I do have one study that I'm going to talk about that looks at one treatment that was studied in this group of patients. So on the left in the box here is a list of different types of acute leukemia based on mutations that they were able to identify. And one of the most exciting things about this is that they were able to do this within 7 days of their diagnosis of acute leukemia. For those in practice, when we send off these specialized testing, it generally takes many, many weeks to get these results. So through this clinical trial, they were able to do it in a fraction of the time. And 96% of those patients got their information within 7 days. And then based on that, if they had specific mutations, then they are enrolled on specific trials that had different therapies available to them. So of these, 285 patients were assigned treatment. 50% of them stayed on the clinical trial, which is actually very impressive in terms of trying to get people onto clinical trials. We're always happy when we get 10 to 15% of patients eligible for trials onto a trial. So 50% is excellent. Now, obviously, patients have choices. So they may have decided not to participate in the trial. They may have chosen another therapy, or they may have chosen not to have any treatment at all. So the preliminary observation at this point is that several of the treatments are showing efficacy, and our hope is that some of these will end up being used later on as standard of care for all of these patients. If you're interested in to know, what are the types of patients that were in it, I said you had to be over the age of 60. But in fact, the median age was 72, so these are the really older patients, and about a third of them were over the age of 75. So moving on to acute myeloid leukemia, I'm going to talk about three new drugs that are being used to treat this disease: Afatinib, Venetoclax, and Quizartinib. So the first drug, Afatinib, is one of the drugs that's being used in that BEAT AML master trial that I was just talking about. So in this particular study, you had to have a mutation called IDH2. If you had this mutation identified as part of your acute leukemia, then you could be included in the study. And Afatinib is an IDH2 inhibitor. And the way it works is that it allows those leukemia cells to turn back into regular healthy cells, or mature neutrophils. In the study before this one, the drug worked in patients who had already relapsed. So patients with AML who had had prior therapy They used this drug previously to show that it was very effective. In fact, 40% of patients who had relapsed leukemia responded to an axitinib. And so this study was looking at people up front with a diagnosis of AML to see if this drug alone could be used to treat leukemia. It is an oral drug, so that's obviously clearly an advantage. And as a monotherapy, this is very useful because patients don't have to take multiple drugs to treat their leukemia. And so they got 4 cycles worth of treatment, and then they were assessed to see if they were in remission. If they are in remission, then they continued on the drug by itself. If they were not yet in remission, then azacitidine, which is another drug that we use to treat leukemia, was added to see if that would help those patients. So when we look at what happened to those patients, 44% of them actually received a complete remission after 4 cycles of therapy, which is pretty amazing for this drug as a single agent. So this trial certainly shows significant activity in patients with a specific type of leukemia, the IDH2 mutated, and patients who are not eligible really for our usual intensive chemotherapy. It was also reasonably tolerated. There was a side effect, something called differentiation syndrome, and that's when those leukemia cells differentiate or kind of turn into those healthy neutrophils that we want, but sometimes it's a little too much at once, and it can cause a lot of inflammation. It might cause patients to have difficulty breathing or some swelling in their lungs. And it is something we have seen in patients treated with acute leukemia multiple times before. So as clinicians, we're used to treating that, and they usually respond very well to a course of steroids. There was no fatal events as far as I could understand from this syndrome. So overall, very well tolerated, much better than what's available to patients currently in this population. The other drug that was mentioned a few times for acute myeloid leukemia is a drug that I'm quite familiar with from a CLL perspective and lymphoma perspective, but now it's being used to treat AML. So venetoclax is an interesting drug, and it helps cause cell death. So one of the ways cancer escapes treatment is that it doesn't know how to die. So by giving a drug like venetoclax, it turns on the cell death pathway, and the cancer cells can die. So obviously that's attractive in many patients with malignancies, and it is being used on various hematological malignancies. And so there are 2 trials where venetoclax was used in combination with other standard therapies for leukemia. Low-dose cytarabine was one of them, and that was in the first abstract. And by combining them in older patients who had never had treatment before and were not eligible for more intensive treatment, they were able to get very rapid, deep, and durable responses. And then venetoclax in combination with another drug, the one I mentioned before, azacitidine, also induces rapid and durable responses in patients with leukemia ineligible for intensive therapy. And the second study actually is the motive for a new study where patients are receiving this drug with azacitidine, and this is ongoing. In fact, we had this particular study open at our center in Calgary for some time. And if it proves that adding venetoclax to azacitidine in this group is better, then this will lead to a new standard of treatment for this high-risk population. Lastly, I mentioned an axitinib, but there's another drug called ivosidenib. It's an IDH1 inhibitor rather than IDH2. So patients who had either one or the other mutation received this drug plus standard chemotherapy in patients with newly diagnosed AML. So this is actually the younger set, more who are usually the ones getting intensive chemotherapy. And if they had this specific mutation and received the drug, the combination was very safe, was very effective, and led to really deep complete remission. MRD negative refers to minimal residual disease, and what that means is that they cannot detect any leukemia cell whatsoever, even with the highly sensitive techniques. So this is something that, again, if it improves long-term outcomes, remission rates are one thing, but being able to prove that patients stay in remission longer or live longer after this therapy, again, it will change what we do for patients with leukemia. Now, it is important to note that these mutations aren't in all patients, so testing for it will become very important. I believe it's about 15 or 20% of patients with AML that have the IDH mutation. So obviously it's not going to be for everyone, but it'll become increasingly important to identify mutations that are associated with leukemia before deciding on treatment. One of the important mutations that we routinely check for in all new patients with AML is something called the FLT3. So this particular mutation occurs in about 25% of patients with AML, and it's not a good thing to have. So if you have acute leukemia that has the FLT3 mutation, this generally means patients are more resistant to chemotherapy, they have higher rates of relapse, and need more treatment. And most of the time, we consider doing a stem cell transplant if they're fit and eligible for that. There is a treatment currently that we give patients called midostaurin. This is a FLT3 inhibitor that is given with induction, and again, that has proven to give benefit to those patients. But quizartinib is better because it's an oral drug. It doesn't have to be given intravenously. And it is also more selective, and so its side effect profile is better than this midostaurin. So this particular study, unlike with any study with leukemia, it's generally first looked at in patients who have relapsed. And so this is patients who have either relapsed after therapy that they received prior. They're included under the study to receive either the quizartinib or they get another treatment and usually another chemotherapy treatment. So what was picked was up to the physician that was treating the patient. And so they compared these two treatments, and it wasn't for long. It was for I believe it was for 15 days. They received the quizartinib, and then they looked at what happened to these patients. So as you can see from the graph, you know, it isn't much in terms of their survival. I mean, if these patients generally have no other options and are likely to die from their leukemia. So the salvage chemotherapy was only associated with the survival of 4.7 months, but the quizartinib was a little bit longer, 6.2 months. And I think that is significant. It may not be much at the beginning, but to say that it's got an effect in relapse disease is very important, especially one that's got an overall survival benefit. So this is something that should be made available to patients if we are able to, because it does show a survival benefit. And the idea is that if we can move this to earlier in the disease course, maybe we can make a bigger difference. And so that's what's going to happen. So we have the Quantum First study that's ongoing, and in this study, patients get standard chemotherapy with or without the quizartinib as their treatment, and we'll see what happens. So I do think that this drug will have the potential to be part of standard of care in patients with relapsed leukemia, but I suspect that it'll move even earlier in the disease course and be available. Now, in terms of side effects, again, it's not like regular chemotherapy. It's an oral drug. So the biggest ones that most patients would complain about are stomach upset or nausea. That's generally very mild. The important thing is when compared to chemo, it actually had less frequent side effects. And so obviously it's not just better in terms of disease control, it's better from a side effect profile. So moving on to the other acute leukemia is the lymphoid leukemia, or ALL. The two things I want to talk about is Blinatumomab, which is an antibody therapy, and CAR T cells, which many patients are asking about these days. So B-cell ALL is generally the leukemia seen in children. So I would say more than 80% of leukemia is going to be in that category. And the good news is that children with ALL have an excellent prognosis with standard treatment. So this is definitely a success story in terms of the management of a childhood cancer. But it's not 100% success, and there's always going to be a group of patients that need more therapy. Blinatumomab is one of those new therapies, and it's already Health Canada approved in patients with B-cell ALL who have relapsed after standard treatment. They have to have relapsed from 2 prior lines of therapy. What we don't know is whether it's effective in first line or whether it's better to do that. So there were a couple of studies that were presented looking at Blinatumomab as a part of the frontline treatment. And in these studies, initially they want to know if it's safe to do that, giving Blinatumomab with chemotherapy, and it certainly is. And in one study where they give Blinatumomab with a regimen called Hyper-CVAB in adults, usually young adults, this definitely showed some excellent activity, and it would be nice to see, again, in the future, whether or not it makes a long-term difference. And the second, I think, is actually more important because there's a group of patients that don't tolerate chemotherapy well, and that's the older patient with newly diagnosed ALL. They will not qualify for many of the intensive chemotherapy regimen treatments, and so they're often given more gentle therapies. So by doing that and adding an antibody in an older age set, and in this study, the median age was 75, the important thing is that the treatment was very well tolerated. And actually 2/3 of patients were alive and half of them were disease-free after the treatment. So, 50% cure rate in this age group is not heard of, especially with the standard treatments that we have. So I think Blinatumomab is another drug that we're likely to see more of. And there are actually some ongoing Canada-wide clinical trials looking at this drug in first line in patients with ALL. So moving on to CAR T cells. Well, I'll first tell you what the CAR T cell is. So CAR T cells, it stands for chimeric antigen receptor T cell. So our immune system relies on T cells to identify and destroy cancer cells. And many cancer cells find a way to escape our own immune system. So CAR T cells were created to overcome this. So they're basically re-engineered T cells that are taken from the patient with the cancer. They are brought into the lab, and through a complex process, the T cells are then converted to attack a specific protein or antigen on the cancer cell. And then those T cells are given back to the patient, and then those T cells then find the cancer cells and then target them for destruction. So it's a complicated process, but it is using the patient's own immune system against the cancer, which is very attractive. And the nice thing is that these CAR T cells act for a very, very long period of time. In fact, they're supposed to act permanently in the patient. And so as long as the cancer has that antigen, the T cells will recognize it and destroy it. So Health Canada has already approved CAR T cell therapy, the TZgen like Lucil therapy, for patients with B-cell ALL through the age of 3 to 25. So that was part of the study. You have to be in that study between the age of 3 and 25, who has failed, again, 2 lines of therapy. So although Health Canada has approved it, it is not yet funded by any province, and it's going through that process right now in terms of petitioning for specific funding. So this particular study is really just showing the update of the long-term data. And what's important is the remission rates are prolonged, and the overall survival rates are excellent. So we're talking at 18 months, 70% of patients are still alive and well. And keep in mind, these are the small fraction of patients who have burned through multiple lines of treatment. They get the CAR T cells, and we're getting a 70% cure rate. That, again, is something quite attractive for this patient population. And the curve on the right here certainly shows this, that pretty much after a year's worth of treatment, you're going to stay in remission if you stayed in remission that long. So very exciting stuff, nice update long-term that tells us that this therapy is definitely worth the long-term benefit for these young patients who would be expected to be contributing to society for decades to come if they're alive and well. So that was it for leukemia, the acute leukemias. And I would like to move on to chronic lymphocytic leukemia and lymphoma, as I think there are some really good data for treatments that, again, are going to become available for patients as a new standard of care option. So the first one I'd like to talk about is Ibrutinib as frontline therapy for patients with CLL. So many patients who have CLL currently will know about this drug, either because they're receiving it currently, often for relapse disease, or because they have high-risk mutations that makes them eligible to receive it at frontline. But it is a therapy that generally every patient with CLL will end up receiving. The CLL is the most common adult leukemia, and there are more than 2,500 new cases in Canada each year. Now, thankfully, not everybody requires treatment. Some patients can stay on observation for many years before requiring therapy. But when patients do have a significant disease burden, usually with multiple lymph nodes, or they have anemia, or they have a big spleen, or they have a lot of symptoms related to their CLL, then they will require therapy. And in most places, the standard therapy is going to be chemoimmunotherapy. So some patients will receive regimens called FCR, BR, which stands for Brentuximab, or Corandisol or Blinatumomab. So those are the 3 most common chemoimmunotherapy regimens that patients would receive frontline. Ibrutinib is available as a frontline therapy in different provinces, but it does vary depending on what the patient's population is and their CLL characteristics are. As an example, in Alberta currently, Ibrutinib is only available frontline in patients who have a specific mutation called the deletion 17p. And I think that's pretty consistent across the country in terms of getting that for that mutation. But for anything else, it's only available in the relapsed setting, at least in Alberta. And in Ontario, I believe, you can get Ibrutinib not only with the deletion 17p, but other important poor risk mutations, something called deletion 11q, or the mutated IGHV mutational status. If you have it unmutated, it puts you at higher risk, and so I believe Ontario will fund patients for Ibrutinib in that scenario. So if you want to know whether you're a candidate for Ibrutinib frontline already, you'd have to ask your hematologist about your CLL and whether or not you qualify. What I'd like to present today is 3 trials looking at Ibrutinib versus chemotherapy for patients who have never been treated for CLL before. So one of the studies is called Illuminate, the other one's Alliance, and another one is a combination ECOG-ACRIN study. So the Illuminate study is for older patients. So these are usually the patients in their 70s who wouldn't do well with very harsh chemotherapy, and so they're often give a combination of an oral drug called Chlorambucil and an antibody called Obinutuzumab. That would be the current standard of care for those patients in provinces, particularly that don't have Ibrutinib otherwise. So in the Illuminate study, it compared Ibrutinib with Obinutuzumab versus Chlorambucil Obinutuzumab, kind of a head-to-head type of thing. The main difference between the 2 treatments is that the Chlorambucil Obinutuzumab is a short-term 6 months of therapy as chemotherapy. But Ibrutinib is a combination treatment. The combination is for 6 months, but then you have to take the Ibrutinib pretty much until you have either side effects or you relapse in your disease. So you're on therapy continuously. So that does make a difference in terms of patient lifestyle. Do they want to be on therapy for a very long period of time and deal with the side effects of some of those therapies? Or would they prefer a treatment that's just for 6 months? And so this study looked at a couple things, and one was whether or not staying on the treatment, which is the Ibrutinib, makes a difference. And the answer is yes. So if you're on chronic suppressive therapy, you're going to do better, which was not a surprise to any one of us. So you stay in remission longer if you're always on treatment. But many patients don't really want that. And so what was more important is if I stop the therapy or I only get the chemotherapy, and then if something happens or if I progress and then I start the treatment then, which is generally what we're doing now, patients getting Ibrutinib when they relapse, will it make a difference in terms of my survival? And the answer is no. So there's no impact on overall survival. So certainly you will keep your remission longer, but it won't affect how long you will stay alive well. And so it is kind of a bit of a balance to decide what patients want. And the problem with being on continuous therapy is that there are some long-term side effects associated with Ibrutinib. In particular, the death from taking Ibrutinib was almost 10%, and they were usually cardiac-associated deaths. So this drug is known to cause arrhythmias, and in older population, that's a much bigger problem. So it is a bit of a balance, and that's probably why there was no difference in survival, is because there was a little bit of excess deaths on the Ibrutinib side. So when you're choosing therapy frontline, we have to kind of take that into balance, taking into the toxicities, and not to mention the cost. So taking a drug continuously for the rest of your life is going to be quite expensive from a health funding perspective. And if there's no advantage to doing that from a survival perspective, then the argument is that we really shouldn't be doing that. And so interestingly enough, this was proven again when Ibrutinib was compared to Brentuximab, which is a different chemotherapy drug that tends to be given in patients generally between the ages 65 and 75. The healthier older patient who doesn't have a lot of complications or other medical issues. It is harder in terms of its side effects. Lots of patients do complain of fatigue, I've had a couple that had to be admitted because of infections because of chemotherapy. So it's not an easy treatment to go through, but definitely controls the disease well. And again, when compared to Ibrutinib, taking it continuously certainly keeps patients in remission longer. But again, no difference in the long-term outcomes, no difference in overall survival. So the authors concluded you had to take into account the toxicities and the costs. And in this case, the death rate from Ibrutinib was about 5%. So a little younger set, we said. So a little less in terms of risk, in terms of dying from the treatment. So at the end of the day, really no big difference. So I don't think these first two studies are going to change what we do in Canada. Personally, I think we should be giving chemoimmunotherapy in patients with low-risk disease, and then discussing with patients what their preference is. Would they prefer to be on a time-limited therapy for 6 months, and then when they relapse, take the treatment? Because it could be many years between relapse, and they may want to have this treatment-free period. The third study, however, was different. So this particular group is actually the least common group. So the average age for patients with CLL who requires treatment is going to be over the age of 70. This study was looking at the younger patients, the under 70 set, and compared them to what we would say is the current standard of care, something called FCR, fludarabine, cyclophosphamide, rituximab. So this particular treatment is generally what we give to our younger CLL patients. And the patients who have a particularly good prognosis CLL, the mutated IGHV CLL, they do very, very well with chemoimmunotherapy. So this particular study was looking at that, comparing, again, Ibrutinib with rituximab versus our standard option, the FCR, and seeing if it made a difference. And as opposed to the other two studies that I just mentioned, it does make a difference what you do first. So if you look at all the patients who are treated, if you got Ibrutinib, you not only stayed in remission longer, but you actually had a better survival. And so when we looked at what were patients dying from in this study, the people who were dying in the FCR arm were dying because of disease. So that to me is very important. That's what you want to prevent. If you're going to give patients therapy, you want to give them a drug that works to prevent them from dying from their cancer. So this particular study does show that the best option frontline is Ibrutinib with rituximab. And so I do think this will change practice in Canada. And we are already in Alberta looking to petition the government to fund FCR frontline for this patient population because of this survival difference. The caveat to that is the lowest risk CLL patient. So in this particular study, they didn't actually show a difference in the patients who had a mutated IGHV. And what that means is if you give the 6 cycles of FCR, you could potentially cure a patient and they never require therapy again for their CLL. So I do think it's still important to look for this and offer them that treatment as opposed to the Ibrutinib, which they'd have to take lifelong. Switching gears a little bit, peripheral T-cell lymphoma. So this is a very difficult lymphoma to treat, and the main reason for this is because it's uncommon. It's rare compared to the B-cell lymphomas that we're used to, accounting for usually less than 10% of all non-Hodgkin's lymphoma. It's part of my practice. It's probably less than 5% of patients that I see in my practice. And in addition to it being rare, patients tend to present with more advanced stage disease, stage 3 and stage 4, which is then obviously more resistance to treatment and associated with poor outcomes. There are very few clinical trials looking at treatment specific for T-cell lymphoma. And generally, we've just been giving them treatment that we normally give for B-cell lymphomas just without the rituximab. Rituximab is specifically for B cells. So T cells are generally treated with CHOP or some other CHOP-like treatment, and the cure rates are not very good. We're talking a third of patients at most are going to be in remission long-term. So we really need new treatments for this group of patients. Brentuximab vedotin is a antibody conjugate that actually has already been shown to be effective in patients with relapsed refractory T-cell lymphoma. And in many places, you can get treatment for those patients who are what we call CD30 positive. The antibody is an anti-CD30. So if your T-cell lymphoma is CD30 positive and you've relapsed after treatment, you can get access to therapy. So why not use it front line like any other trial? You show that it's effective in relapse disease. Let's move it up earlier to see if we can cure more patients. So this is exactly what they did. Patients with a new diagnosis of T-cell lymphoma that were CD30 positive either received the Brentuximab CHOP regimen or the regular CHOP regimen. And it was a randomized trial, so you didn't get to pick which treatment you got, obviously. And the average age is about 58. The majority of patients had a specific type of T-cell lymphoma called anaplastic large cell lymphoma, and that is still, out of all the T-cells, that is not the most common, actually. The peripheral T-cell NOS, or not otherwise specified, is the most common, but the way the trial was conducted is that they were recruiting more of the anaplastic large cell lymphomas. It was mandated to do that. But a lot of other types of T-cell lymphomas were included. So this is important when we're trying to apply the results to patients after we look at the results. So I like this because it shows a survival benefit. So if you get the rituximab, if you're in the group that got the rituximab with their CHOP treatment, you did better. Not only did you stay in remission longer, what we call progression-free survival, but overall survival was better. And our funding agencies in Canada prefer that. They want to see that it makes you live longer. And in this particular case, the difference was really significant. So in patients with who got the Brentuximab, you stayed in remission more than twice as long, 48 months versus 20 months. And you were less likely to die from your disease. So the trial is important in many different ways. This is the first trial in T-cell lymphoma that showed adding a new therapy makes a difference in terms of outcomes. And I do think this will become a new standard of care first line for patients with T-cell lymphoma in Canada. And in the interim, while we're waiting for drug funding, we have a program where we can get a kind of a division approval for this rare malignancy, right? So this is what's important. These patients are not common. So if you have a new diagnosis of T-cell lymphoma, find out from the pathologist whether it's CD30 positive, and definitely ask about this particular drug, because you may receive, there might be ways of getting funding for it while we're waiting for universal funding. So we talked a little bit about CAR T cells for ALL. Well, the other indication that is Health Canada approved for CAR T cell therapy is for a disease called diffuse large B-cell lymphoma. Diffuse large B-cell lymphoma, it is the most common aggressive non-Hodgkin's lymphoma. In many cases, we can cure the patients with standard R-CHOP treatment. So this is the standard treatment for diffuse large B-cell lymphoma across the country is going to be R-CHOP therapy. However, this disease is aggressive, and unfortunately relapse occurs. and occurs commonly, particularly in patients who are advanced stage or have other high-risk features. If you're younger and fit, then the standard salvage treatment is with a stem cell transplant, and half of those patients who get a stem cell transplant will be cured. But the other half, unfortunately, will not be cured, and relapse will lead to death, because very, very few patients can be salvaged with the current therapies that we have available. So there are 2 commercially available CAR T-cell therapies, the Tisagen-Lacluso one that I mentioned, which is Health Canada approved in patients who have failed at least 2 lines of therapy. And then the axicabtagene siloluso, or Axi-cel for short. This one is awaiting Health Canada approval. Neither one is funded in Canada. Should be good. All right. Then we have, I just wanted to show a few more slides on this. This is just the long-term outcome, ZUMA-1, which is the original trial looking at outcomes for patients with diffuse large B-cell lymphoma who got CAR T-cell therapies. And what's most important, again, is that the long-term cure rates are quite good. So we're talking 40% of patients are still in remission, and more than 50% are still alive and well. So I think this is another treatment that can give long-term outcomes in patients with multiply relapsed disease. What I wanted to show you is just the experience of using this therapy outside of clinical trials. So as a clinician, when I have access to a new therapy, I'm going to be using it on many different patients who may not have been eligible for the clinical trial for many different reasons. Maybe they had a blood clot, or maybe they had low platelet count, or something else that would normally exclude them, but wouldn't exclude them clinically from receiving the therapy. And so they looked at patients who received this therapy outside of a clinical trial, what they called the real-world experience, and they were able to get data from over 300 patients. And 43% of them actually would not have made it into a clinical trial. So these are higher risk patients for sure. And what's the most important thing is that it was safe to use. So when they compared patients who received the standard of care off clinical trial Axi-cel versus those in the clinical trial, the rate of side effects, serious ones like cytokine release syndrome and neurotoxicity, were no different between the 2 groups. And the treatment-related deaths were no different between the groups. Neither was hospitalization rate. So I think expanding this to people outside of clinical trials will be a reasonable thing to do. And I always like to show pictures because it really tells you the story of how well this therapy works. So the guy, this guy is heavily pretreated. You could see that he's had 7 lines of chemotherapy prior to his Axi-cel therapy. And he is not the best patient. He has a poor performance status. ECOG of 3 means he's in bed probably 50% of the time. His EF, that's the cardiac function, his heart function is only 45%. Normal is about 60 or more. He's had a pulmonary embolism. He's had bleeding. And now because of the cancer, he has jaundice, and he has to have a tube in his gallbladder to drain the biliary fluid. The picture on the left is a PET scan. Anything black is related to his lymphoma. So you can imagine how much disease this person has. The picture on the right is 1 month after the Axi-cel, which is the T-cell directed treatment, the immunotherapy, patient's own immune cells attacking the cancer. And I think that's so dramatic, that response, and that's fantastic. Of course, we'd want to offer this therapy to patients. So moving on to multiple myeloma, I have 2 studies I want to talk about. One is with Daratumumab for multiple myeloma. So multiple myeloma is a different type of cancer. It's a cancer of the plasma cells in the bone marrow. Again, fairly frequent, 3,000 new cases diagnosed in Canada each year. Lots of different therapies that are available in the last 2 decades. And all of these have contributed to long-term outcomes. Daratumumab is another antibody, a monoclonal antibody. This time it's anti-CD38, and it's approved to treat multiple myeloma. And there was a lot of trials at ASH talking about this new antibody. So the first study is just showing an update of combining the daratumumab with VMP, which is a standard regimen for newly diagnosed multiple myeloma. And what it shows is that if you have the combination, you do better from a progression-free survival benefit. And so these patients are staying in remission longer. Even if they get multiple therapies after, they stay in remission much longer. Now, VMP is not what we use here in Canada in terms of our first-line therapy. We generally use something called Cyborg-D, but the Myeloma Canada Research Network has previously demonstrated that it's equivalent. So VMP does just as well as the Cyborg-D. So in theory, adding daratumumab to Cyborg-D should be feasible and just as effective. The same thing was demonstrated with a different upfront regimen, lenalidomide dexamethasone, again showing a significant improvement when you add daratumumab to the Revlimid dexamethasone regimen. It reduced the risk of progression or death by 44%. So this clearly shows that adding daratumumab is going to make a difference in multiple myeloma patients. Now, I believe daratumumab is already funded in the relapse setting in many places. So I suspect they are going to petition to add it in frontline. And it is going to make a difference. It's going to keep patients in remission much longer, which is something we certainly want to achieve in multiple myeloma patients. In fact, there's good data to support, again, MRD negative status, where we can't detect any detectable disease, which usually is the first step to a long-term cure. So stay tuned. I suspect daratumumab will be seen much more frequently in patients with multiple myeloma. And this slide I've just added as just more of interest than anything else. Revlimid dexamethasone is a standard induction treatment, but the problem with many multiple myeloma regimens is that you're kind of on this continuously. And the longer you're on the therapy, the more side effects you have, and the more likely patients are going to stop treatment because of these side effects. And then if you stop treatment, then you lose the efficacy of the drug, and then you relapse. So this particular study was looking at whether or not they could reduce the treatment dosing to make it more tolerable to patients, to keep them on treatment longer, and then improve their survival. And so that's essentially what they did. And they picked patients who would really be at high risk for complications. So there's more the frailer type of elderly patients, kind of over the age of 75 with comorbidities. And then they randomized to standard treatment, standard doses, versus a reduced dose after a period of induction. And they were able to show that by reducing the dose, you're going to keep patients on therapy longer, that their survival rates were actually better, and that they had less toxicity. So it is something to consider in patients who are frailer. To reduce the dose, you're not going to lose anything by reducing the dose. So it is something more of a practice type of thing that some of us who treat myeloma will adopt. The last thing I'm going to talk about is just some supportive care abstracts that were discussed. Both of these were very important in terms of where they were in the conference. The luspatercept one was one of the plenary session topics, the top 6 abstracts at the conference. And then the apixaban for cancer-associated venous thromboembolism was late breaking, so something that's going to change practice. So the MEDALIST trial, that's what they called it, was looking at using this drug, luspatercept, in patients with myelodysplastic syndrome, a specific type of MDS that had ring sideroblasts. And this particular MDS is generally associated with more anemia that requires blood transfusions. And if you require blood transfusions, you actually have a poorer prognosis. The treatment options are actually quite limited for this particular group. Some of them, they get EPREX, which is a hormone that's used to stimulate red cell production. But many of these patients either don't qualify for the EPREX or become unresponsive to it, and then end up just getting transfusions on a regular basis, which has its own side effects. So luspatercept is a different type of drug that acts on stimulating red cell production. And they were able to show that people who received the luspatercept did better. They were able to become transfusion independent. Or if they didn't get independence, their number of red cell transfusions were reduced. And they certainly got higher hemoglobin levels. And then what's interesting, after a defined period of time, the people who responded actually remained transfusion independent at a year. So it was not a long-term treatment. They received it for, I believe, I can't remember exactly, but they received it for a defined period of time, and then they stopped, and then they stayed a transfusion independent. Treatment was very well tolerated, and so I do think this may be another tool in the arsenal that the patient with MDS could use to improve their quality of life, improve their transfusion needs, and hopefully translate into longer survival. Lastly, this is I think an important study because patients often ask this question about the blood thinners. So unfortunately, many of our patients are diagnosed with a blood clot, either a deep vein thrombosis in the leg or pulmonary embolism, or often both, either at the time of their diagnosis or while they're on therapy. And so the standard of care has been injections with low molecular weight heparin, often tinzaparin or dalteparin. And that's been that way since I was a resident for almost 20 years. But now we have these new oral agents that are being used regularly in non-cancer patients. And so the question was, is it safe to use and as good to use compared to the standard injection? And the answer is yes. The apixaban that was used in this particular trial was very well tolerated. It was associated with lower bleeding risk than the standard injections and reduced rates of thrombosis. So everything you'd want out of that. It's as effective, if anything, less toxic. And what's important is patient satisfaction was better. So patients are much happier taking pills as a blood thinner compared to injections. And so this data certainly support the use of apixaban for the treatment of acute cancer-associated VTE. And I've already started to adopt that in my practice, particularly in patients who have funding for it. So this is my summary slide. I think the ASH meeting, as always, presents very exciting, relevant, practice-changing research that certainly impacts the everyday care of my patients. And I think will change what we do in Canada for many of the conditions I talked about today. Why I go? Well, I think patients are the motivations for this progress, and I want to know what happens across the world with patients who are involved in clinical trials. And really, I think that's one way to improve patient care, not just for the patients themselves personally, but for all patients who have a diagnosis of hematological malignancy. So I think for all patients who have active cancer, either new diagnosis or have relapsed disease, ask your doctor, is there a clinical trial available for me? Because you'd be surprised, many times you'll be offered better treatment on the clinical trial than standard of care. So please ask your hematologist, cancer specialist, whoever manages your care about that information.
Thank you so much, Dr. Stratify, for showing us how research is advancing. The Leukemia and Lymphoma Society of Canada will continue to do its part to speed up the discovery of better treatment options. We will now begin to take your questions. Please remember to use the chat function. I have a few questions that have already come in. Okay, so I am a patient in Toronto diagnosed with ALL tumor lysis in April 2016, was given hyper CVAD first followed by DF, intense, and maintenance. Used rituximab, in remission now, had blood pathology indicating T-cell clonality, PCR, as suspicious. Are there any markers that I should be looking at to see if relapse occurs?
So generally when we look for disease relapse, we look for the leukemia phenotype that was present at the time of diagnosis. So the pathologist should have records of this, and they should be able to identify whether there's a population that is identical to the one that was made at the diagnosis. So that's how we define relapse, is by looking at the cells and seeing if it's the same. T-cell clonality is a little bit different, so I don't know, if you got rituximab, that tells me yours was a B-cell ALL. So saying you have T-cell clonality is kind of non-specific. I don't know how to interpret that. That could just mean you have a response to a viral infection, maybe EBV or CMV or something like that. Or it may signify something else. So I do think that needs to be followed, but it would not be related to the original disease.
Thank you so much. I have another question here, and bear with me again, there's a lot of abbreviations. Given a 16-year-old male who has recently completed the SOC, as Brentuximab, I think it was called, was not yet available, would he be offered another course out there? If and when relapse occurs, wouldn't he be offered the SOC as well as the Brentuximab, Vedotin, or the Brentuximab alone, or something else? The NHL is ALCL, ALK positive.
So if he's not had Brentuximab previously, then he certainly should be offered that if his lymphoma is CD30 positive. If he has had Brentuximab and he got a response and now he has relapsed off of therapy, sometimes we do offer retreatment. So it really depends on what happened the first time.
Thank you. I have another question here. Are there any clinical trials for myelofibrosis? Also, what is the criteria to get on this or those trials?
Yes, there are, in fact. We have one opening up in Calgary ourselves. So I do think it's important. So I didn't actually touch upon myeloproliferative disorders. It's really hard to pick and choose everything. And there wasn't anything kind of practice changing at ASH this year. But there are new therapies out there for myelofibrosis and other myeloproliferative disorders. So I would definitely ask and get to know who does them at that particular center. So we have our own kind of local myeloproliferative disorder expert in Calgary, and she has already opened a clinical trial. So it may very well be at your center as well. You just have to ask.
Great, thank you. I have, and how do I get to know more about it? It was in relation
to the clinical trials?
Yes.
Okay, so there are a few ways to do it. I think the easiest way to do it is to talk to the hematologist. The second way is to go to clinicaltrials.gov. And then what you can do is put in the filters. You can put in the name of the disease and then the location. So you can just say Canada if you wish to know what's happening in sites across the country, or if you're in a particular center. They're usually done in academic centers, so a center that's affiliated with the university. So in Alberta, that would be in Edmonton and in Calgary. But if you live in Lethbridge or Red Deer, which is a community place, that doesn't mean you couldn't participate in a clinical trial. It would mean you would have to be treated in Calgary and Edmonton. But sometimes people are accepting of the travel to do that.
Thank you so much. Have any studies been done on the connection between diet, especially a plant-based diet, and the effects on cancer progression or cure?
Not that I'm aware of. I think those ones are more difficult to conduct, and there doesn't seem to be a active interest in doing that. Obviously, many of the studies that are presented are pharmaceutical based, and they have the money to do the funding to obviously at the end of the day promote their drug. So I do think those things are important. It would be lovely to know whether or not changing your diet makes a difference in terms of cancer outcomes. I think it's a hard study to conduct because patients are, while they're undergoing treatment, are not well enough to make some big changes with their diet. We certainly don't want them to lose any weight while they're on treatment. And there are other factors that may influence absorption of drugs, particularly some plants, and grapefruit in particular is a no-no for many of the therapies that we have. So it would be difficult to conduct, but a very important study to conduct if it was feasible.
Thank you. I have another question here. So Eprix worked for me in stimulating my red cell production after complications post-transplant.
Right.
It is very expensive, and fortunately, I was directed to a program that provided coverage. Do you know of any progression on this drug, or if it would be available as part of a treatment program?
I use the same program to support funding for that. Chemotherapy-induced anemia is a problem, and I've had to use it multiple times after patients who've had a stem cell transplant. The good news is the funding agencies have never turned me down every time I've asked, so it hasn't been an issue in terms of coverage for patients. Alberta Blue Cross does cover it for very specific indications. Unfortunately, for patients with myelodysplastic syndrome, that's not the case, and so we have to go through other avenues. I think one of the programs we use is called the Spectrum program. But we manage to get things for patients in other ways as much as possible. We're good at advocating for patients when they need specific therapies.
Excellent, thank you. There we go. I have another one. I take methotrexate each week and my liver is improving. I might take this only from time to time. Is there another suggestion that you may have?
That's a non-specific question, unfortunately. I don't know what the reason for the methotrexate is.
Mm-hmm.
I don't know what the disease is for the methotrexate.
Okay, so she has LGL leukemia. That is a kind of lymphoma.
Yeah. So actually, if the methotrexate is working for you in terms of controlling the disease, even at a reduced dose, then generally most of us would continue with that. It's always a balance between the toxicity of the treatment and the control of the disease. There are other treatments for LGL. A drug called cyclosporin is another therapy that I have used. Another drug called cyclophosphamide. Each of them has their own kind of side effect profile and efficacy. And to be honest, I think methotrexate works the best. So if it's working for you very well, and it's still keeping you in a reasonable response even with the decrease in dosing, then my preference would be to continue with that.
Thank you. We have time for one more question. This question is, how would it be decided if bone marrow transplants or Ibrutinib would be the best for relapsed CLL for a 60-year-old?
Very, very, very good question. So transplant, I have a huge allo transplant practice, and I pretty much see everybody with CLL in Alberta. So I get to answer that question on a regular basis. So if you were in front of me and you were on Ibrutinib for your CLL and you were 60 years old, and I knew certain things about your CLL, we would have a frank discussion about the timing of your transplant. I think you'd still be young enough to wait for a stem cell transplant. But if you had really high-risk disease, and I'm talking about the mutation deletion 17p specifically, then I would try to convince you that this is the best time to do it. Get your disease in remission, and then do the stem cell transplant. The salvage treatment for patients who progress after Ibrutinib is venetoclax. It's not currently funded in Canada, but it is available through a compassionate program. They have not pulled the compassionate program yet, but I don't know how long that's going to stay. So it is a gamble if we wait while patients are on Ibrutinib and offer them salvage treatment if they progress. But I do that. I think it's worth the gamble on patients with lower risk CLL, because you could be on Ibrutinib for many years. The average is actually 5 years on Ibrutinib before requiring another therapy. So if you have low risk CLL, I would not do a stem cell transplant. I would keep you on the Ibrutinib, and then when you do progress, because we usually have warning about that, we would consider doing allo transplant at that point.
Excellent. Thank you so much, Dr. Shafee. So before we head out, I would just like to remind everyone to not hesitate to contact us if you need more information by calling toll-free or by email at canadainfo@lls.org. Also, check out our website regularly for the dates of our upcoming webcasts or to watch all past webcasts. Please note that a survey will be sent to all participants after this presentation. We will greatly appreciate you taking a moment to fill it in, as it will help us to offer you the most valuable information in the near future. Thank you so much for joining us, and have a nice evening.